Welcome.
Hello, everyone. How are you? We are so excited to have you here today. I am Jody Smith, the program director of the Mended Hearts Inc. And I also have Mandy Sandcooler on the line, and she's going to help us with some questions. And today we have Dr. Paul Mahoney, who's going to present on mitral regurgitation. What is MR and how is it managed? Some things to know is all of you all are in listen only mode. That means we're not going to be able to hear you, but luckily there's a Q&A box. So if you locate the Q&A box, if you're on a device, you might have to hit the ... and you should be able to type questions into that box. It helps if you do that instead of the chat box, because then we can look at the questions all in one location. If you ask questions about your specific condition or treatment, we cannot answer specific treatment questions on this webinar because no one on here most likely is your treating physician. And this webinar is being recorded and will be available on the Mended Hearts Inc. website at www.mendedhearts.org and on our YouTube channel. This is part of a series. So this webinar and the series is brought to you by the Mended Hearts Inc. in partnership with Abbott. This is part 2 of the 2-part patient education series featuring leading providers as well as patients who have experienced mitral valve regurgitation. And you can view part 1. It is on our YouTube channel and at www.mendedhearts.org. You can get to it either way. And it's a patient panel. It's absolutely fabulous. So if you haven't seen that one, and you are a patient living with mitral valve disease or caring for someone who does, I highly suggest you go look at that webinar. And we also just want to thank all our speakers today and Dr. Mahoney, and we want to thank all of you for being here. If you would like to join Mended Hearts, Young Mended Hearts, or Mended Little Hearts, simply go to www.mendedhearts.org. And memberships start at $0, so it's a bargain. I'm going to turn it over to Azure, and she is going to introduce Dr. Mahoney.
Okay, thank you so much. Well, hello, everybody. Thank you so much for joining us today. And as Jody mentioned, we are going to be covering mitral regurgitation. What is MR and how is it managed? And a quick note as we get started, this program is sponsored by and on behalf of Abbott, and the speaker for this program has been selected by Abbott and is presenting the program material on our behalf. So as we take a look at what we're going to be covering today, I think it's important to highlight that our agenda for today is based directly on the feedback of a group of patients who have lived through being diagnosed and treated with MR. So they have told us this is what they would have wanted to hear earlier on in their journey, and we hope that you're going to find it helpful. So we will be spending a little bit of time first understanding the basics, really what is mitral regurgitation or MR, and then walking you through the pathway of symptoms, right, how it can present through diagnosis, and then ultimately exploring some different treatment options for the disease. And last, and I think very importantly, we wanted to make sure that everybody on the call today had some practical tips they could take away if they have a loved one in their family or they themselves are experiencing MR. So we will be leaving you with some advice for patients and caregivers. And we are very excited today to have really a thought leader in the treatment of MR who has extensive experience treating patients who have this disease. So Dr. Paul Mahoney is currently co-director of the Heart Vascular Institute Structural Heart Program at UPMC. Dr. Mahoney, I am happy to turn this over to you. And I will drive slides for you.
I'm really excited to chat with you guys today. We really want to talk about the heart. We want to talk about certain valves in the heart. And we want to talk about mostly the mitral valve. So I'm going to give you a quick refresher on our heart. Just confirm you guys can still hear me?
Yes, we can.
Perfect. So I'm an interventional cardiologist. I work at UPMC, and I spend most of my time repairing or replacing faulty valves inside the heart. And the typical heart has 4 chambers. Okay, there's the two upper chambers, we call those the atria. Those are where blood returns from the body to go into the pumping chambers. And the two bottom chambers are called ventricles. And those chambers pump blood either to the body or to the lungs. Those chambers are separated by heart valves. And the purpose of the heart valves, like any valve, is to allow flow in a single direction. Any engineers amongst you will say the ideal valve will allow blood to flow in one direction without impedance and offer complete protection against backflow. We do see a lot of variability in a biological system. These aren't mechanical valves, these are biological human valves. And so there's a lot of play in them. They can be lax tissue, and there can be a little bit of leakiness back and forth. And we're going to concentrate on the mitral valve today. If you could go to the next slide, please. Okay. Thank you. So a normally functioning mitral valve, that's the valve in the panel on the left, that's the valve on the right. That separates the left atrium from the left ventricle. When the heart beats, that valve should close, forcing the blood to go out the aortic valve. The bad things can happen with the mitral valve. It cannot open properly or it cannot close properly. And if it doesn't close properly, when the main pumping chamber squeezes, half of the blood can go backwards. More than half sometimes. And this makes the heart very inefficient. Imagine trying to merge onto a highway going up the on-ramp in first or second gear. The heart doesn't have the ability to increase its cardiac output. It doesn't have the ability to increase the amount of blood flow. And therefore, the engine of the body is severely compromised. And you might be okay sitting at rest, but if you get up to walk to the mailbox or go up a flight of stairs, all of a sudden you become very short of breath because that valve stops the heart from increasing its cardiac output. And that occurs when the valve doesn't close properly. Regurgitation simply means backflow. You know, babies regurgitate, they throw up. This valve will have blood going in the wrong direction. Show me the next slide, please. So there's two types of mitral regurgitation. MR is shorthand for mitral regurgitation. There's primary MR, and as you might expect from the name, when primary MR means when the valve itself is the problem. It doesn't close properly completely. One analogy I'll commonly use, you think of a circus tent, and there's structures that hold that surface tent taut and to the ground. There's tent pegs and there's ropes that go to the tent. If the tent pegs or those ropes were to break or rupture, the integrity of that tent is compromised, and you might see it collapse or wave in the wind. That can happen with the valve. The tethers under the valve that control it can sometimes break. This can happen just over time, or this can happen following things like a heart attack or just out of sheer bad luck. And that structure of the valve is compromised. That's primary MR, where there's a problem with the valve. Secondary MR is the valve is more or less okay, but the structure in which the valve lives, it's a fibrous ring called the annulus. And when you think of like a six-pack of Coke or beer with those little circles, the plastic tabs, think of two of those. The valves live in those. And if those are stretched or pulled, a valve that might be perfectly competent in the proper sized annulus or ring all of a sudden gets stretched, and there's a broad central jet of leakiness because the valve is now too small to occlude the hole it's supposed to be in. And this can occur when the ventricle, the main pumping chamber, enlarges. And that is most commonly seen in patients with heart failure who have a weakness of the muscle. So primary MR is a problem with the valve. Secondary MR is a problem with the muscle that's transmitted to a problem with the valve. We'll go to the next slide. So what does this mean? Who has MR? Well, mitral valve disease is actually the most common valvular heart disease, and almost 10% of people over 75 will have it. That's a lot of people. That's over 4 million people. This can be anything from mild to very severe and very limiting in terms of functional status and even how long you live. And we estimate that less than 2% of people actually get treatment for this. Secondly, when this is present but not treated, the long-term complications over time can be fairly severe. It can lead to irregular heartbeats, atrial fibrillation. It can lead to high pressures in the lungs. Just like you take a pressure in your arm, you take a blood pressure cuff and measure the pressure in your arm, get a blood pressure of 140/80. The lungs themselves have their own blood pressure. And that constant backflow of blood through the regurgitant valve puts pressure on the lungs and raises the pressure, and that causes a problem called pulmonary hypertension. And then you're all familiar with congestive heart failure. One of the causes of congestive heart failure is a bad valve. This will lead to really sharply limited functional status. Again, you know, like that car idling in the driveway, you may be okay at rest, but God forbid you try to increase your activity or increase your exercise, and you just can't because of the limitations of that heart valve. And so you get very short of breath. You can and you can have a greatly diminished quality of life. This has an impact not only on the patient but everyone around them. You know, if you can't walk up a flight of stairs, if you can't walk out to the end of the driveway, you're probably not going on a lot of excursions during the day. Go to the next slide. So what are the symptoms? Now, let me just preface this by saying symptoms are not necessarily the diseases. Being short of breath can be caused by many things, but valve problems is one of them. So we sort of look at both the symptoms that people complain about, and then I'm going to talk to you about how we diagnose what the problem is. So the symptoms of a leaky heart valve can be something as vague as fatigue. You just don't have any energy. It can lead to a cough. Really, the most common one we see is shortness of breath, and that's exertional shortness of breath, not just when you're sitting around, but when you get up and try and do anything. Heart palpitations can be sometimes indicative of this. Really severe cases, we can see fainting. And then chronic fluid retention, which it manifests as swollen ankles or feet, is another sign of heart failure and inefficient heart. So really, it's kind of non-specific. I can name 10 other things that can cause any of these, but if you start to experience these things, these should prompt an evaluation by a physician who can pretty rapidly figure out what's going on, I hope. Next slide. Well, how do we do this? Now, I'm not going to, this is a bit of an eye chart, so I apologize for that. But this is kind of our algorithm for looking at secondary MR. Like, how do we diagnose and treat that? I will tell you the hallmark of the first phase of taking care of somebody who has a weak muscle. Remember, this is secondary MR. This isn't a bad valve. When we see a bad valve, we just got to fix the valve. There's no intermediate steps. But if someone has a bad muscle causing the valve to be stretched, if you can fix the muscle, sometimes the leaky valve gets better. So the first thing we do is medicine, okay? Once we're optimized on the medical therapy, then what we'll do is we will see if there's still a leaky valve. So what happens? Let's start on the left side. The patient experiences symptoms, okay? They go to the primary care provider and you take a look, and usually what they'll say is, we think this is cardiac. They'll order some tests. That might be an EKG or an echocardiogram. And usually at that point, they'll send you to see a cardiologist, all right? And there's different levels of specialty within cardiology. You'll probably see a general cardiologist first, and they'll try to rapidly decide, is this a heart rhythm problem? Is this a heart valve problem? Is this a muscle problem? Is this a blood supply problem? And once they're able to triage that, if it turns out that we have a leaky valve problem, we'll start with the medication, okay? Now, again, if the structure of the valve itself is compromised, we skip the medication. We just go right to repair or replacement, because there's nothing that's going to treat that. But if it's a weak heart causing a leaky valve, then we'll try to treat that, as I said. So to go to the next slide. So what are the treatment options? I already talked about medicine. So we have something that's called, the fancy name for it's guideline-directed medical therapy. And what does that mean? That means using our best available evidence, what trials that we've done, what medicines have we proven will improve symptoms and improve longevity, improve survival in patients with heart failure. And we make sure people are on those. All right. They can be ACE inhibitors, angiotensin receptor blockers. Entresto is a very commonly used and very popular drug. Beta blockers, and even things that are also designed to treat diabetes can sometimes be used. All right. Once that's stabilized, if you still have a leaky valve, then we start talking about fixing the valve. One of the things I specialize in is catheter-based repair of the mitral valve, and that is done using a device called a Mitra Clip. It's an edge-to-edge repair. And I'll just take a little bit of a diversion. This was originally developed from a surgical series treating infectious cardiomyopathies in South America. What does that mean? People get infected by a certain infectious agent, and their hearts would dilate and they develop bad heart failure. This surgeon found that if he repaired the heart, and including he would sew the middle part of the heart together to reduce the leakiness, those patients did better than if he didn't do that. We can do that without having to cut your chest open. We go from the leg and repair the valve by taking a device called a Mitra Clip, approximating the two edges of the leaflets, and reduce the leakiness that way. It's a very safe procedure, and we can improve your functional quality of life, and we can improve your survival. Sometimes the Mitra Clip doesn't work, and we even talk about things like a valve replacement. Valve replacements traditionally are done surgically. That's with cutting open your chest, stopping the heart and putting a new valve in. We, in some circumstances, can now do that with catheters as well. All right. But these are all, we're getting far down the field of what we can do. So I'd want you to discuss this with your cardiologist for the most part. Next slide. Okay. So what does this mean from from a patient standpoint? How can we help you? So the first thing you want to understand is that if you're feeling kind of miserable, you're getting really short of breath, your ankles are swelling, you can't do the things you want to do. There's a lot that can be done. We have a lot of new technology, a lot of less invasive technology that can help. So develop a support structure. You're not alone in this. Your physician can help you, your family can help you. Get as much information as you can. Things like this seminar are helpful. Be clear about your goals with your heart team. Okay. And what I mean by that is, I don't feel well. I want to feel better. Okay. If you're okay with your quality of life and you just want to make sure that things aren't going to get worse and you're not exposing yourself to a risk, that's one thing. If, on the other hand, you're miserable and something needs to be done now, let us know that. All right. And ask lots of questions. What are my options? What are the alternatives? What are we going to do if this doesn't work? And then, the Philadelphia 76ers fans out there will understand the last one. Be patient and follow the process. And there is a process. It takes a little bit of time with mitral regurgitation. Aside from a rare case when we have just a torn cord or some dramatic thing with the valve, for the most part, we're going to take a stepwise approach, see if we can take care of it with medicines, see if we can take care of it with diuretics. And if not, then we'll go in there and we'll start talking about repairing or replacing valves, if that makes sense. Next slide. So, here's what we talked about. Family, friends, and caregivers can play a critical role. Whenever possible, bring someone with you to a doctor's appointment. All right. It's very nice to compare notes afterwards in the car, in the waiting room, or when you get home. It's very nice to say, what did he say? Or what did she say about this? Or what do you think they meant by this? Or what order are we going to do this? Help organize appointments and medications. Try to be hyper organized. Bring lists of medications with you to the doctor's offices when you go. All right. And ask questions about options, plans, and how you can help. The more informed you are, the more you demonstrate to physicians you're engaged and interested. You may prompt them. They're busy. They're seeing lots of people. But, if you're asking them, hey, what other treatment options are available? Or can they fix this valve with something besides medicine? Or is this a candidate for that? You may jog something and say, what, let me think about that. Or let me send you to my colleague who's a specialist in this, or, we'll at least look at that. So I would encourage you to just be part of your treatment, be engaged and be active and take an active role in taking care of this so we can all help each other. Next slide. All right. So that's what I have. That's a very broad overview. And I just wanted to make myself available to answer any questions that you may have regarding this. So if anybody has any questions, or I think Azure, we're going to use the chat. Is that correct?
Yes, this is Mandy, and we are going to use the Q&A actually, doctor. So I've got a couple of questions. Can MR cause diastolic dysfunction?
So that's a great question. Let me first explain what the person is asking. Diastolic, the heart can have dysfunction two different ways. Okay, it can have a problem with squeezing, and it can have a problem with relaxing. All right. Squeezing is the traditional thing you think about heart failure, where instead of having a normal squeeze, the squeeze is greatly diminished. The heart just is weak and doesn't pump very well. Diastolic dysfunction is a little bit different in that it is when the heart has become stiff and thick and no longer expands. So imagine you take you have a leather bag and you have a glass container, and you pour water into the leather bag. Once you get to a certain point, it'll stretch a little bit, it'll give a little bit, and you'll have a little bit of distensibility. A glass container, however, once you get to a tipping over, a filling over point, it just starts leaking. All right. And hearts with diastolic dysfunction are not leather type, they're the glass type, and that can lead to a lot of heart failure from that. Traditionally, we don't see that so much with mitral regurgitation. All right. Although it can cause heart failure and it can cause a lot of these very similar symptoms, it's not usually due to a leaky valve. It's usually due to things like hypertension or disease process that can infiltrate into the heart, is where we usually see that. So it's a good question, but they tend to be separate problems that have very similar symptoms.
Okay, thank you. Sheila asks, can dilation of the left atrium lead to secondary MR or worsen existing primary MR?
Yeah, these are great questions. Yes, the short answer is it can. There is something called an atrial myopathy, where you can have severe left atrial enlargement that can cause the annulus to stretch. And when that happens, we can get an atrial myopathy. And an atrial myopathy, it will functionally act the same as cause a leaky valve. It'll stretch the valve and cause a lot of leakiness. So that can happen.
Okay, thank you. What is the criteria for repair versus replace?
So that's a good question. When we can repair it, that tends to be a simpler fix while surgically with catheters, and oftentimes when it's a straightforward repair, we'll go that. And that's an anatomical criteria for the most part. What that means is your valve will tell us whether it's a repairable valve or replaceable valve. Certain diseases are not amenable to being repaired. Rheumatic heart disease, for example, or very calcified valves, or valves that have previously been infected, generally speaking, are not repaired. Other valves, such as stretched valves with secondary MR or a primary MR problem where you've got a cord that snapped and we can just tack that up, they are very amenable to being repaired. So usually the criteria that we use are anatomical criteria based on what your particular valve looks like. And we usually determine that with things like echocardiograms and transesophageal echoes to sort of look at that. But that's a good question.
Mm-hmm. Michael asks, does mild regurgitation usually transition to moderate and then severe regurgitation over a certain period of time with older patients?
The short answer is no, and that's because you use the word usually. It certainly can. The vast majority of patients that have a little bit of leaky valve will go their whole life, fat, dumb, and happy, and then die of something else. A small subset does progress. All right, we don't know everything we need to know about which patients are going to progress and which won't. We can certainly follow them. Patients that have a lot of prolapse, for example, very, very stretchy valves that are more laxity than we usually see, those are a little bit more prone to it. But we don't know enough about it. The majority of people with just a mildly leaky valve will probably never progress, but some will. So if we're worried about it, we can follow that with serial echocardiograms.
Thank you. Can you tell us more about the tests that you do to diagnose MR? Are they different than other heart issues, or are any of them invasive?
Yeah, they're a little bit different than tests. There's a lot of overlap, meaning that a transesophageal echo, which is basically an endoscopy tube that goes in the esophagus and looks at the heart from the inside out, is a very useful test for a lot of different valve problems. That is technically considered a non-invasive test, but if someone's going to stick a tube down my throat, I might consider that invasive. So there's no cutting you open. There's no sticking tubes into the body anywhere to do that, but it is involved sedation and a tube down your throat. That's a pretty important test. A lot of the tests are not invasive at all. A regular echocardiogram, a transthoracic echocardiogram, we just put some jelly on your chest and shoot some ultrasound through the chest wall, and that is other than having to take a towel and clean the goop off you, is a pretty straightforward test. Then there's a whole bunch of other tests that we do. A CAT scan can be done. That's not invasive. A heart catheterization is invasive. That's where we put catheters inside the body, go up into the heart, measure pressures, and look at the arteries. And that's very commonly done as sort of the last step before a final repair or replacement. If that helps.
Okay, yeah, that was very helpful. So Lisa has a question that I think a lot of people probably have to deal with this with family members. Her dad has all the symptoms you listed and the fluid retention is bad, but he won't even go to his primary doctor. She's just wondering, where does she even start with getting him help?
Oh my gosh. Yeah, Lisa, that's a great question. A couple things. We can only help people in general who want to be helped, and there's lots of I'm a interventional cardiologist. I'm in this for 20 to 25 years. My dad has some heart problems. He kind of listens to what I tell him. Mostly he doesn't. But he, I will, I'm his son, so he doesn't necessarily want to listen to me. But if you get him in front of, if you can convince him that he might live longer, be less of a burden, get him in front of somebody who can start to work with him and help him and engage him in his own care, that would be very good. There are some people for whom, if they don't get a diagnosis and they don't have a problem, especially older patients, if I'm not on medication, I must be okay. And if I don't go to the doctor, they won't put me on medication. So therefore I'm okay. A lot of times we just end up meeting these people in the emergency room. They let it go for a long time to the point where they get into trouble, and then they get exposed to the healthcare system on an acute care basis. And that's not, we're happy to help them and we will help them. And lots of times we can do a lot of good at that point. It's not ideal. We'd love to, do this in a more controlled fashion before people get into trouble. You can provide them literature. You can, ask them, you can try to engage some of their friends to help you. At the end of the day, though, someone has to be engaged into their own care. And there's lots of people out there who just, for whatever reason, maybe it's fear or anxiety or just stubbornness, don't want to address some of this stuff. So one thing you do is say, hey, I heard a physician speak, I heard a doctor speak. He said a lot of these symptoms could be caused by your heart. They could be fixed. And if you wait too long, then you might miss a window where they could be fixed, and supply that information. And hopefully something will resonate. If there's another sibling or family member, you may want to engage them. And, you don't want to, badger or nag anybody. But on the other hand, if they're kind of ignoring their health, that could become your problem just as much as their problem if they end up getting pretty sick. So I wish you luck with that. And I would start with trying to get them somewhere if they can. So it's a tough problem.
Okay, thank you. At what point would you repair or replace a mitral valve with 2+ regurgitation to prevent the development of AFib?
Great question. Right now that would be managed medically. We've been looking at this pretty carefully as a group. We just published a 2,000 patient series that we did repair on, and mixed in with them, there was a fair amount of patients that only had 2+ MR at the time of intervention. This is on a research basis because this is not necessarily standard of care now, and the patients did pretty well. What we have to do is study the problem a little bit more. We have to, kind of in a randomized sort of controlled fashion, take 500 patients, take 1,000 patients with this problem. 500 we can repair, 500 we won't, and see which group does better. We haven't done that yet. So right now I can't advocate that. I think there's a lot of research interest in exactly what you're describing, but we haven't proven it yet. So right now, repair replacement is reserved for patients that have more than 2+ leakiness. If you do have 2+ leakiness, I would follow kind of closely and just get echocardiograms every year or so and make sure that it's no progression of that. Or if you start having symptoms like we described, I would go back and get reevaluated.
Okay, great. Can diet cause or prevent primary mitral valve regurgitation?
Nope. It certainly won't cause it, and it's unlikely to prevent it. Primary MR is a fundamental problem with the valve, which either comes from some laxing the tissue, or things like an infection, or rheumatic fever, or calcification. So it's probably not directly going to be caused or prevented by diet. It is one of those things that can just happen, and when it does happen, we just got to fix it, unfortunately.
Okay, yeah, thank you. How does mitral valve prolapse relate to MR?
Mitral valve prolapse is laxing the valve, which means that if you think of rather than like a door slamming shut, think of like some curtains billowing in the window. They kind of parachute. The tissue becomes a little bit redundant and a little bit excessive, and so when the heart squeezes, it'll hold, but it kind of parachutes or pushes up into the left atrium. And over time, if that stretchiness gets to the point where it no longer is competent, then prolapse can become regurgitation, and that does occur. Most people with prolapse do just fine with it, but it is a risk factor for progression, as someone was asking earlier. So.
Okay. Thank you. Is ablation one of the repair procedures? And can you explain that procedure?
So ablation is, so divide the world of interventional cardiology into two broad groups. One group would be electricians and one group would be plumbers. All right. The valve specialists are the plumbers of cardiology. We repair valves and we, replace valves. The arrhythmia specialists, the electrophysiologists who manage rhythm disturbances, are the electricians, and they're the ones who do the ablations. And what they'll do is if someone has an irregular heartbeat, usually atrial fibrillation, they will go in and they'll try to use a series of catheters and wires to ablate or cauterize the area where the arrhythmias come from, and therefore maintain and restore sinus rhythm. Because atrial fibrillation is so common in mitral regurgitation, there's a lot of overlap. A lot of the mitral regurgitation patients will have an ablation for their AFib, but ablation does not necessarily directly treat the mitral regurgitation. Now, there was just a big study at the European Congress that showed that patients with cardiomyopathy who had successful treatment of their AFib by ablation did a little bit better than those who didn't. So there's going to be more and more overlap, but they do not directly treat the same problem.
Okay. Is it possible that if a patient waited too long, it might be too late to have any type of repair or replacement done?
Yes. Yeah. Unfortunately, the natural history of what happens with this is that the heart will continue to stretch and dilate and stretch and dilate. And if it gets too far down the road, then it can get too dilated for us really to make a difference. And unfortunately, when that happens, we have to offer transplant or assist devices. Now that's pretty rare and it's pretty end stage, but it can happen. So there is a window of opportunity for repair.
Okay. A couple of questions about the Mitra Clips. Can you explain how they work? Can you feel them, and do they ever fail?
Sure. How they work is they're sort of a very fancy clothespin. So it's a clothespin not with two arms but with four arms. So think of like two clothespins joined at their tip. So we grab one leaflet with one clothespin, another leaf with the other clothespin, and then we close the whole apparatus together. And what that does is it creates a double outlet valve, meaning instead of one big hole, it's like a figure of eight. You see two orifices coming down, and that can reduce the leakiness and reapproximate the edges of the leaflets. And that's how it works. They're independently grasping elements, and they pull the healthy tissue back together to restore a competent seal. Once they're in, you cannot feel them. You're not aware that they're there. All right. And it's not like one of these valves you hear clicking at night. You won't feel or hear it at all. You'll just feel better. And what was the third part of that question?
The third part was, do they ever fail?
Yeah, I mean, sure. I mean, everything can fail. The latest data that we have shows that their patency rate at 5 years is well in excess of 95%. Sometimes though, because we're not really fixing the underlying process, we're kind of repairing it without stopping the stretch. If the valve continues to stretch, sometimes within the next 3 to 10 years, we'll have to go put another one on to try to touch it up. Every once in a while, they can pull through if the leaflet tissue quality isn't good enough. That being said, the most recent data that we had showed that at 1 year, 93% of patients had only mild leakiness after repair, and 97% had a pretty good result with moderate or less MR. So the majority of these patients, 97+%, are getting very good results that are durable out at a year. And we think that's great. But they can fail. I mean, like every other thing we do with valves are pretty complicated, and we don't really have the perfect answer to every problem. So they can occasionally fail.
Okay, thank you. Is there anything you can do to prevent the primary MR from progressing from mild to severe? Is there any research on this?
So primary MR is a problem with the valve. There's no medicine or diet you can have when there's a primary problem with the valve. It just is what it is. You can try to control the symptoms with things like diuretics and medicine to slow or stop the process. But in general, if you have a primary problem, you need to fix the valve if the patient will tolerate it. Secondary MR, There's lots of things that medicine can do. And we can actually see somebody with severe MR, put them on appropriate medical therapy, and then within 6 to 8 weeks, the MR goes back down to mild, and we just leave everybody alone. And by making the muscle more efficient, we made the valve work better.
Okay, thanks. And I think we've got a few more questions. We'll just ask you those and then we'll finish up. But this woman's been on medications for a while. How does she know when they aren't working anymore? Because now she's starting to feel more tired and breathless, but she can't tell if it's aging or if it's just the medicine's not working.
Great question. I think we need more information. I think the way to tell if it's working is to get reevaluated. It can progress on medication. People can be stable for a while on medication and some heart failure, they're doing great, and all of a sudden their symptoms start to percolate to be a little bit more. An echocardiogram can be done to see if there's all of a sudden more leakiness or more dilatation or more enlargement of the ventricle of the heart. And in that case, we can change gears and intervene at that point. So if you're starting to feel a little bit worse, despite you're being compliant and taking your medicines, and you fear that they're not working well, go get checked out.
Okay, thank you. And okay. When is a catheter-based mitral valve replacement a good option instead of a surgical replacement?
So they're all, it's basically based on, right now, the standard of care for mitral valve replacement is a surgical valve replacement. That is the standard of care. That's the best we have to offer right now. Catheter-based valve replacement is a subject of intense interest, and there's a lot of, because not everybody can have surgery. So for people who the anatomic problem would require us to replace their valve, but the patient themselves, you don't want to win the battle and lose the war. You don't want to operate on somebody, and yes, we have a successful operation, but the patient, spends 6 months in a nursing home, or God forbid, doesn't make it through. So for people for whom the surgical risk is high, the attractiveness of catheter-based valve replacement is pretty high. So if you're judged by your team to be high or prohibitive risk for open heart surgery, we will look very carefully to see if a catheter-based valve replacement would work for you. I just want to emphasize, though, those are research right now. They're all in research protocols. I expect us to have some approvals in the next year or two, but that hasn't happened yet. So just bear that in mind. On the other hand, catheter-based repair is commercially available. It's FDA approved, and we would look for that first to see if that's an option.
Okay, thanks. We're almost done with the questions. Is it common to have a mitral valve and tricuspid valve regurgitate in a heart that's damaged?
It's unfortunately, it is pretty common. And the reason for that is when the mitral valve backs up into the lungs and causes that pulmonary hypertension, that puts pressure on the right side of the heart, and then that side of the heart dilates, and that valve leaks as well. So very often we can fix both valves by fixing the mitral. We get in there and we fix the mitral valve, and we shrink down the size of the left ventricle, and we get no regurgitation. The lung pressures come down, the right ventricle gets smaller, and then that leakiness stops, but not always. So they very, very commonly appear together.
Thank you. And I've just 2 more questions to go.
Sure.
You've been so patient with our everyone. Thank you so much.
Oh, no problem at all.
Can MR get to a worsened degree of regurgitation when you exercise?
Well, sort of. What can happen is if you have a valve that's moderately leaky, but there's a fundamental, but you're at risk, and your heart starts beating more vigorously, which is what happens when you exercise. Your heart rate goes up, and your heart starts working harder to keep up with the increased cardiac demand. Sometimes the valve will become more dysfunctional. And so we have some testing we can do. We can actually put people on a treadmill and check echocardiograms before and after exercise and see if their leakiness gets worse. And there's some people for whom the MR worsens with exercise. And that's a real signal for us to try to repair or replace that valve.
Thank you. And finally, last but not least, can endocarditis lead to valve problems?
Yeah, so endocarditis, yes. And I'll take that in 2 stages. Endocarditis in and of itself is a valve problem. Endocarditis means an infected endovascular surface, which is usually a valve. So most cases of endocarditis are valve problems, the vast majority. They can be transient and treated with antibiotics, and the valve is none the worse for the wear, or they can cause damage to the valve itself by sort of chewing it up. the infection can cause the valve to have actual problems and leakiness. And that's usually not fixable by repair because the valve has been physically damaged. Now, if it's a chordal structure, if it's something we can use an edge-to-edge repair and try to reapproximate it, we can sometimes help with that once the infection is cleared. But endocarditis in and of itself is a valve problem and then can cause long-term valve problems if it causes some damage to the valve itself.
All right, thank you. Well, I'm going to turn it over to Jody so that she can come back on and close us out.
Yes, thank you so much, Dr. Mahoney. And we will have this recorded and we will on our YouTube channel and on our website. And we also have two wonderful handouts for everyone. We have a discussion guide, which is a trifold guide on mitral regurgitation, and we have an infographic as well. So we will share that with all of you who attended, and we thank you for being here. Everyone have a great night.